Rohan,
3, 2, 1. We are live now.
Hello? Or
No, sir, you can start.
sure. Good evening, ladies and gentlemen. Welcome to another exciting episode of Secrets of Neurology, Knowledge Feast for all neurologists. Today is episode 55th. So we are inching very, very close to our fifth year of completion. And in the Secrets of Neurology, today we will see interesting case of ataxia, where we would see collaboration from two great medical college of the country, Travancore Medicity Medical College and Government TD Medical College, Alpuza. All this has been due to the untiring effort of two of our course director, Professor Dr. Sudhir Shasar and Professor Dr. Lakshmi Narsimhan. A warm welcome to you again, sir. And I would also like to warmly welcome Professor Madhusudan, Dr. Saji, and Dr. Aparna, who would be collaborating for the case today. We all know it by now that this is a short and sweet case discussions, normally continue for a period of 1 hour. Sir, the gentleman whom we see on the screen has been giving untiring inputs in the field of neurology, including the secrets of neurology, Professor Dr. Sudhir Shasar. We know him very well. He's professor and HOD at prestigious SMT-NHL MMC and SVP MSI Ahmedabad. Professor Sudhir Shah sir is also Director of Neuroscience at Sterling Hospital, Ahmedabad. Many awards and accolades to the credit, but I would keep it very brief as he always guides me to do that. Author of 6 books on neurology. Because of his contribution to community at large, service to mankind, research and patient service, he was also conferred various prestigious awards such as Padam Shri. He is also recipient of BC Roy Award, and very recently he was also awarded as French Senate Palais du Luxembourg, which is the highest international award for Indians. Professor Dr. Sudhir Shasar's interest is into stroke, neurodegenerative disease, and epilepsy. Thank you, sir, for always supporting and guiding us. Our second course director, Professor Dr. Lakshmi Narsimhan Ranganathan, sir, Director and Professor, Department of Neurology at prestigious Sri Ramchandra Institute of Higher Education and Research, Chennai, and he went on to also build Madras Medical College. Many awards and accolades, but I'll keep it brief. Paltussi Advisor A.B. Baker's Award, his contribution in the field of academics and nurturing young talent down south and across the neurology faculty has been extremely immense. Warm welcome to all the lovely delegates who join us in large number across the world. I can see numbers are going all around just now in hundreds. May I request Professor Dr. Sudhir Shah sir to take it forward from here?
Thank you. Thank you, Dr. Manoj, for this nice introduction. I welcome all the delegates to this wonderful series, that is Secrets of Neurology. Specifically, this is episode number 55. And it is a great honor, and maybe it's a privilege to say that all of you have been very kind to us. You have been constantly inspiring us to continue this wonderful knowledge-based series. And we we are grateful to all the medical colleges of all 55 episodes who have generously agreed to talk about their cases, and the professors have dissected the cases very nicely. And this has become now as archives in YouTube also, so we can retrieve from there also. I'm very happy to note that every time we have lots of delegates from across the country, and not only that, but from nearby countries also. And sometimes we have delegates logging from USA, Spain, Canada, UK, and other parts of Europe also. So thank you for your patronage. Now, I want to thank first of all my colleague, Dr. Naseem, Lakshmi Naseem, whose constant and untiring efforts have made this series so popular. And also, I'm thankful to Celestial Division of INTAS, led by Mr. Chadda and Dr. Manoj and others, and for their networking, for their infrastructure and logistics support. Today, we have a case from Government TD Medical College, Alappuzha, by Dr. Aparna Amarnath. She'll be the senior resident who will present the case, while Dr. Shaji CV, who is the professor HOD from the same institute, who will do dissection, localization, all that. And we will have none other than the great master of medicine, neurology, Dr. Professor M. Madhusudanan, is the professor in HOD, Department of Neurology, who will give summary conclusion and his pulse of wisdom in this particular case. The case is about progressive ataxia with some elements of dysphagia and dysarthria. I don't know the diagnosis, so I'm just vague in describing. May I have the next slide, please?
Sir, one correction. I will be discussing the case and Shaji will be giving the final comments.
Oh, great.
Reverse. Okay, there's no problem.
Sure.
I'll be discussing the case.
Sure, but
Disclaimer.
ultimately you will have to give some final comments.
Yeah, sure,
we
sure, sir.
we would
Sure, sir.
love to listen your words of wisdom at the end also again, sir. All right. So Aparna, welcome Aparna. She is from Government TD Medical College, Alappuzha, and she is senior resident from the same college. Next slide, please. Dr. Shaji CV, you know, very knowledgeable personality, professor in HOD, Department of Neurology of Government TD Medical College, Alappuzha. He is MBBS from same college, MD from Government TD Medical College, and DM Neurology from National Institute of Neurology, Nimans, Bangalore. He is MPhil, doctorate in Behavioral Science from MG University. He has Bhaskar Verma Memorial Award 2022, Best Doctor Award from Health for All Foundation, IMA 2022, Best Doctor Award from Kerala Sadguna Triplana Sangam in 2015, and John Abraham Award Best Doctor in 2014. And he has more than 12 publications in reputed Indian journals. And is writer of neurology portion of Sarva Arogya Nigandu. Next slide, please. Who does not know Professor M. Madhusudan in India and abroad? He is a wonderful personality or asset. He is professor and HOD of neurology, Travancore Medical College and Hospital, Kollam. He has been teacher of teachers and master of masters. So we all have a lot of affection for him. He is affiliated to the Travancore Medicitic Medical College, Kollam. He is adjunct professor of neurology at Manipal University, Manipal, senior consultant neurologist at PRS Hospital, Trivandrum, professor emeritus Medical College, Trivandrum, and former professor HOD Medical College of Kottayam. He has 44 publications in national and international journals, contributed 90 chapters in textbooks of neurology and medicine, published books on higher neural functions and neurological evaluation, pulse and pitfalls. In fact, I ordered a copy of last book 2 days back only. It's a wonderful book. Every DM student must read that book. Awards and achievements, lots of them. Few of them are like the winner of the Pan Samuel Award for the best research paper in '98 and Lifetime Achievement Award by Newcon in 2014. Was awarded the Master Teacher Award by Shine, awarded the Lifetime Achievement Award from Numerical Society of India in February 2020, and awarded the Lifetime Achievement Award from the Madras Neuro Trust in 2025. So with this, I hand over the mic to Professor Shaji to conduct today's webinar from now. Thank you very much.
Thank you, sir. Thank you, sir. I first of all express my gratitude for giving this opportunity to present our case in Secrets of Neurology. I am honored to be the moderator of Dr. Madhu sir and Dr. Aparna. Shall I call Dr. Aparna the presenting the case? Shall we start, sir?
Yeah, of course. Can start.
Dr. Aparna, can you present the case? Dr.
Okay,
Aparna.
Okay.
Okay.
Sir, is it visible?
Yes, yes.
Good evening, everybody. My patient is a 57-year-old male who is an aluminium fabricator worker from Cherthala, presented with complaints of sensory symptoms in the right lower limb since 2 years and unsteadiness of gait since 2 years. History of presenting complaint. He was apparently normal 2 years ago. He presented with insidious onset, slowly progressive sensory symptoms as burning sensation in the right lower limb, started in the anterolateral aspect of the thigh, slowly crossing the knee and descended up to anterolateral aspect, lower third of the leg in 1 year. No precipitating or relieving factors, no symptoms suggestive of any radicular pain or low backache. He also noticed slowly progressive tingling sensation of the feet, occurred almost simultaneously, initially in the soles, progress to involve up to dorsal aspect of the all toes over 2 years. However, no features suggestive of any wash basin symptom. Since the onset of the sensory symptom, he also noticed unsteadiness of gait in the form of difficulty in negotiating narrow passages, swaying to either sides, right more than left, often bump into the scooter or cycle while walking in the road and used to fall. No worsening of symptom during the night time. Patient gives history of progressive hard of hearing since 1.5 years, which was slowly progressive in both ears. There was no history of any tinnitus, vertigo, or any ear symptoms. He also gave history of progressive hoarseness of voice since 1 year. No history of any dysphagia, nasal regurgitation, or choking episodes while eating food or fluids. No sensory symptom referable to upper limb, face, or trunk. No history of any slurring of speech. No symptoms suggestive of visual disturbances. No history suggestive of any seizure, raised ICT features, or any neurobehavioral symptom. No history suggestive of any tremor, rigidity, hypokinesia. No history of any weakness of upper limb or lower limb. No history of bladder or autonomic symptoms. No history of any sleep disturbances. No history suggestive of loss of appetite, weight, or any other systemic symptoms. Past history, the patient was diagnosed retropositive 18 years back and is on regular ART with tenofovir, lamivudine, efavirenz, and dolutegravir. And a past history of pulmonary tuberculosis at the age of 18 years, and he had taken 6 months of ATT for that. And there is a history of RTA thrice occurred, and the first episode was about 5 years back. And the patient was riding the bike, and the bike collided to the Jeep at that time, and he was hospitalized for about 5 days. The second RTA was about 1.5 years back, and he had a rib fracture. The third RTA, 1 month after the second RTA, and at that time, there was a recurrence of the rib fracture. And he is a hypertensive, diagnosed since 2 years, and is on amlodipine. And there was history of right hip avascular necrosis, and the surgery was done in 2023 under spinal anesthesia. And there is no history of any diabetes, stroke, or any coronary artery disease. Family history, this is the family, this is the pedigree chart. There is no similar history in the family. No history of any hearing loss in the family, no history of any unsteadiness. Personal history, married 18 years back, and he divorced within few days, and he is an ex-smoker, stopped 18 years back, non-alcoholic, consumes a mixed diet, and no exposure to toxins. This is the timeline showing the events. 2 years back, he developed right lower limb paresthesia, sensory symptoms in the right both foot, unsteadiness of gait, and hard of hearing since 1.5 years, and hoarseness of voice since 1 year. Summary: 57-year-old male without any significant family history, with history of retropositive on ART since 18 years, presented with insidious onset, slowly progressive unsteadiness of gait, and paresthesia of lower limb, progressive hearing loss, and hoarseness of voice.
Okay. Shall I proceed? I think I'll start discussing the history first. Now, Aparna, can you take over your slides so that I can share my slides?
Okay, sir.
What happened to Shaji? Okay. Shaji,
Yes, yes,
can I start discussing the history?
yes, yes.
Yeah, right. I'll on my slide. Let me see.
Hello, sir.
Yeah,
Okay.
is my slide seen?
Yes, yes, you can see, sir.
Okay. So at the outset, I would like to thank Dr. Sudhir Shah and his team for inviting me to present this case or discuss this case. Now, I will start from the very beginning. Now, my usual practice to discuss the history itself before seeing the findings, so that it makes some localization of the history itself. So this is important because this will tell you what to look for in the exam. So I'll go back to the first statement. Complaint started 2 years back. There's a total duration. He presented insidious onset, slowly progressive sensory symptoms. as burning sensation in the right lower limb started in the anterolateral aspect of the thigh, crossing the knee and ended up to the anterolateral aspect, lower third of the leg, 1 year, no precipitating relieving factors. Now, where do you localize this sensory symptom? See, obviously, yes, the burning pain mean there's pain fibers are affected in the right lower limb. Where are they affected? Maybe in the spinothalamic tract in the spinal cord, or maybe in the roots, plexus, or the multiple nerves. It's less likely to be in the roots in the absence of root pain because you never complain root pain, but that does not totally negate a radiculopathy. If it was in the spinal cord, the lesion is more likely to be intramedullary since it descended from above. According to the history, the pain first started in the thigh, then it descended down to the leg. So that kind of a progression of a pain loss indicate unlikely to be a lesion from outside coming to the spinal cord, because as you know, according to the lamination, the leg fibers are, the distal fibers are more peripherally situated. So maybe some intramedullary lesion descending and enlarging to cause the progression of the pain below the thigh. The next complaint was he also noticed slowly progressive tingling sensation of the feet, which occurred simultaneously and initially involved the soles, then progressed involved up to the dorsal aspect of all the toes over the 2 years. However, there are no features as to wash basin symptom. So obviously this is a distal onset positive sensory symptom suggesting a touch fiber involvement. It may be in the peripheral nerves, maybe in the spinal cord. Both can produce distal sensory loss like that. However, it seems more likely to be in the cord in view of the fact that the previous area of pain fiber affection was different from the present area of the touch fiber loss. Suppose it had been, this sensory loss had been due to peripheral neuropathy, would I expect the pain loss also to be the same area of the touch loss. But here the pain loss is in a different area and the touch fiber loss is in a different area. So that kind of involvement usually favors not a root or a nerve, more like a cord involvement, because these five sensations are carried by different tracts. Now come to the next symptom. Since the onset of sensory symptom, he also noticed unsteadiness of gait in the form of difficulty in negotiating narrow pathways, saying to either side, often bump into cycle and scooters. There was no worsening during night. Now, could suggest either a cerebellar ataxia or a sensory ataxia. The fact that the patient did not have worsening during night or washed basin phenomena may favor cerebellar, but that is not foolproof because this does not exclude sensory ataxia because he also complained of sensory symptom in the lower limb. So that possibility of a sensory ataxia cannot be ruled out. Now, these points need clarification after examination, whether to find out that ataxia is actually sensory due to posterior column loss, sensory loss, or due to cerebellar involvement. The next symptom was patient gives history of progressive hard of hearing since 1.5 years, which is slowly progressive. So it obviously indicates that bilateral deafness may be sensory or conductive deafness. Since the subsequent history of 10th nerve affection makes me think that hearing loss is also due to nerve lesion rather than a conductive deafness. So you take it as a sensorineural hearing loss. The last history is that he gives a progressive hoarseness in voice for the last 1 year. However, there is no dysphagia or nasal irritation or choking episode while eating fruit or fluids. So progressive hoarseness without dysphagia or choking episodes and nasal irritation favor an affection of the recurrent laryngeal nerves since the palatal and pharyngeal branches are spared. However, a partial affection of the 10th nerve or affection of the lower part of the nucleus ambiguous can also cause this kind of a selective involvement of the laryngeal affection. But more likely rectal laryngeal nerve, but the other possibility cannot be totally ruled out. For example, if you look at the brainstem localization, nucleus ambiguous, there is a nucleus ambiguous. It's a very long nucleus, and the different functions of the nucleus ambiguous are representing different parts of the nucleus. For example, if you look at the lamination, the laryngeal part is represented most caudally, caudal part of the nucleus ambiguous. So if the lesion is happened to occur in that area, the patient may have only hoarseness without any problem in swallowing or in nasal irritation. So that's one possibility can be ruled out here. So as far as the hoarseness is concerned, it may be partial tanzana, it may be recurrent angina, which I do not know now, or even maybe lesion in the lower part of the medulla. Now, other things are all negative history. I'll skip that thing. So where is the site of lesion from the history? And you may ask, why can't we wait for localization after the end of the examination? Sometimes it will be necessary, but I always try to have presumably localization of the history, since what to look at the examination depends upon what you suspect from history. So always I make it a point to have a localization. We let it be wrong, but then from the history or localization, so that you can tune your examination in that direction. So let's see the localization. Now, question, he has got a sensory symptom, something like a peripheral neuropathy. He has got a hoarseness of voice and he has got deafness. So is it entirely a peripheral nervous system problem, or is it lesion of the brainstem which can explain everything? I cannot entirely rule out a PNS problem here. For example, peripheral neuropathy can cause sensory ataxia and patchy pain fiber loss, like a mononeuritis multiplex. And recurrent angina involvement can cause hoarseness without dysphaginous irritation and sensory neural hearing loss. So nothing against a PNS involvement. So all these can be explained by mononeuritis multiplex. Now, what could be etiology inside? Like something like a multifocal involvement, like a vasculitis. The second thing is the other PNS problem, which can produce similar thing is, need not be in the nerve, maybe in the roots. Is affection of the cranial nerves and patchy radiculopathy to explain the sensory loss in the lower limb ataxia, and something like a meningeal disease, like a pachymeningitis, which can involve the multiple cranial nerve, can also involve the multiple radicals. So happen that sensory is affected more than the motor. Maybe on examination of motor weakness, we do not know, reflex changes and all. So maybe a chronic meningitis, like sarcoid, it may be, since the duration is long, maybe a benign type. Sarcoid, Sjogren's, or idiopathic IgG, all this can be kept in the possibility, the second localization. Now, could it be a spinal cord problem causing these sensory findings? It's got a sensory ataxia, it's got some pain loss and the patchy pain loss. It can responsible and that can be explained with spinal cord. Then how to explain the problem now comes if it is spinal cord involvement, how to explain the 10th nerve and the sensory neural deafness. You can think that the lesion extended into the brainstem, but that's very, very unlikely because bilateral sensory neural hearing loss hardly ever occurs without affection of other structures in the brainstem. Because both auditory nucleus are situated far apart. So lesion extending into the brainstem only affecting that cochlear nuclei without producing intervening structure affection is very odd. If at all we can think of spinal cord affection again, we may have to think again of chronic leptomeningeal affection like a chronic meningitis, which can produce adhesia, arachnoiditis in compressor spinal cord. Okay, some of the senses may be due to that. And that arachnoiditis can involve the 10th nerve and the 8th nerve. That's another possibility which we can discuss on the previous slide. Like, for example, adhesia arachnoiditis producing myelopathy and involvement in the cranial nerves. So I think we may have to come back to localization after examination because at this point of time, I'm not sure whether it's the peripheral nervous system or the spinal cord, meningeal disease, which is compressive spinal cord and the multiple cranial nerve, we do not know. So possible site after history is a mononeuritis multiplex or meningeal disease like diffuse pachymeningeal or leptomeningeal disease. Now here the past history is very important here. There are many clues in the past history. See, erythropositive and past history of pulmonary tuberculosis. So the possibility of tuberculosis, lepto, and pachymeningeal disease is likely, except for the long duration. Alternatively, syphilis also should be considered. Bilateral is erythropositive, every chance that you can have a syphilitic infection also. Bilateral sensory neural deafness is a well-known feature of neurosyphilis. Or HIV-induced mononeuritis multiple. This has to be kept in the back of the mind if it is a peripheral nervous system disease after examination. Then he has got a history of hypertension, avascular necrosis of the hip. So that also can be correlated because avian avascular necrosis can occur in SLE and other vasculitis like IgA vasculitis, giant cell arteritis, polyarteritis nodosa, they can also produce. So it's another point that maybe vasculitis affecting the multiple nerves. Another very relevant history is the recurrent head trauma, is 2-3 accidents. the patient had intracranial hemorrhage, which is likely so he can have because of the traumatic hemorrhage. It can subsequently produce a superficial siderosis and can produce affection of all these structures. That is the third thing we have to keep in mind. So I think, so these are the localization which you can think from the history. So what I need clarification after examination of these things, I want to know whether ataxia is cerebellar or sensory, because that gives, that if it's not sensory, if cerebellar, Mona's multiplex is unlikely. If sensory, the lesion is in the posterior column but the peripheral nerve. That is important. I want to look for in cerebellar signs nystagmus. If nystagmus is there, definitely the ataxia is cerebellar. I want to look for reflexes in this patient and posterior column sensory loss and Rombergism to find out whether the sensory loss or ataxia due to sensory ataxia. If it is so, it is in the root or in the posterior spinal cord. Then other thing I want to know after examination is there any evidence of palatal pharyngeal muscle weakness? Because the history is not there, but examination may be there. That also you have to find out the localization, the hoarseness of voice. Then lastly is sensory loss, fitting with the nerve distribution, root distribution, or a tract distribution such as spinal. So let's see the findings now. Okay, Shaji.
Okay, sir. So according to it, is basically a peripheral appears to be peripheral nerve system.
Yeah, peripheral.
Maybe
or a
related to
leptomeningeal disease.
leptomeningeal disease. There is no hardcore symptom suggestive of a neuraxial involvement. So
Correct.
We will go any other queries from the audience with regard to discussion regarding the history analysis.
Yeah, right.
Symptom analysis, any other suggestions from the audience? So I also feel that there's no hardcore history suggestive central interaxial involvement from the history.
Correct.
Shall we go to the findings, sir? Clinical examination.
Yeah, please. Yeah.
If there is no other suggestion, we'll go to the clinical examination. Dr. Aparna, can you?
Yes, sir. Yes, sir.
Discuss the clinical examination findings.
So, on examination, sir, is it visible now?
Yeah, it's already, you can see it.
Okay.
You're audible also.
Sir, on general examination, the patient is conscious, oriented, and pulse rate was 78 per minute, BP 140, 80 millimeters of mercury, respiratory rate was 14 per minute, and he was afebrile, and there was no panorectalus clubbing cyanosis. And the patient has a leonine facies with some hypopigmented papules in the chest as well as in the abdomen. Central nervous system examination. Higher mental function examination, Folstein MMSE was 29 out of 30, of which the recall was affected. The recall was 2/3 and the QOD was also 2/3. And the MOCA was done and it showed a value of 28 out of 30. And the affected parts were delayed recall and error in making the hands of cloak. And the speech, there was hoarseness of voice was present and there was no dysarthria or aphasia. Cranial nerve examination, olfactory nerve, optic nerve, oculomotor nerve, all was normal bilaterally, and the trigeminal nerve, motor part, sensory part, as well as the reflex was normal. The facial nerve was also normal bilaterally. The vestibulocochlear nerve, the Rinne test was normal bilaterally, and the Weber was not lateralized, and the ABC was decreased compared to that of the examiner bilaterally. And the glossopharyngeal and vagus nerve examination was also normal. Uvula was central, and the movement of palate was normal, and the pharyngeal reflex was normal. And the axillary nerve was also normal bilaterally, and hypoglossal nerve was also normal. Motor system examination, there was bulk was normal, and the tone, lower limb spasticity was present bilaterally, and the power was also bilaterally normal, grade 5/5. Reflexes, deep tendon reflexes, lower limb reflexes, that is knee jerk, ankle jerk, was brisk exaggerated bilaterally, and the plantar was extensor bilaterally, and the abdominal reflex was absent. And the release reflexes, the palmomental snout and pout was present, left more than right for the palmomental reflex. Cerebellar signs, there was no titubation, no nystagmus. Finger to finger test was abnormal bilaterally, left more than right, and finger nose finger abnormal bilaterally, left more than right, and the finger toe bilateral abnormal, left more than right, and dystenokinesia was present bilaterally, and the gait ataxia was present, and there was abnormality in the tandem walking. Sensory system, touch was normal bilaterally, and the pain was also normal bilaterally, and the joint position sense, it was decreased in the bilateral lower limb up to the metatarsophalangeal joint of small toes, whereas in the big toes it was normal, and the timed vibration was decreased bilateral in the lower limb up to the lower third of the shin, and the Romberg sign was also negative. No peripheral nerve thickening, no meningeal signs, and the gait was wide-based gait, slightly wide-based gait, decreased foot clearance, and mild dragging, and tendency to fall while turning. Can I play the video of the eye movement?
Yeah. Okay.
There is no nystagmus.
Okay.
The saccades was also normal. There is no hypometria or hypermetria. The vertical eye movements was also normal.
Okay.
This is showing the upper limb tone. Upper limb tone was somewhat normal, but the lower limb tone was increased bilaterally. The reflexes, lower limb reflexes was brisk compared to that of upper limb. Cerebellar signs, there is abnormality in the cerebral side, but there is definite asymmetry was present. Finger nose finger, there is more ataxia, more instability in the left side compared to that of right side, and there was this dystenokinesia. Sorry, this dystenokinesia was also present, and the heel shin test was also more abnormal in the left side compared to that of right side. There is definite asymmetry in the left side compared to that of right side. Romberg sign was negative. The tandem walking was grossly abnormal. The patient was not able to walk in the straight line. And also the walking showed a spastic gait, slightly wide based, with some more problem while turning. So the definite clinical findings we got was leonine facies, hoarseness of voice, bilateral sensory neural hearing loss, bipyramidal signs in the lower limb, asymmetrical appendicular ataxia left more than right, joint position sense decreased bilaterally up to the metatarsophalangeal joint, and the timed vibration decreased up to the lower third of the shin.
So Dr. Aparna, 2 point I want to clarify. What about angle jerk? It is intact? Angle jerk
Angle was brisk, sir.
Bilaterally brisk.
Bilaterally brisk.
Then one point I again want to clarify regarding palatal Is there any evidence of palatal palsy or
No,
anything?
sir, no evidence of palatal palsy.
Okay, thank you. Madhu sir, can you discuss
Yeah,
the
yeah, right. I'll discuss the case. Just 1 minute.
Sir, shall I exit from the?
Yeah, you can exit. Of course, you have to exit. Can you see my slide?
Yes, sir.
Okay, sorry.
can
Sir. Then I'll share once again. I'll share once again. Just 1
Okay.
minute. Can you see my slide now?
Sir.
You can see it.
Yes, sir. Yes, sir.
Okay. Let's see. Now, regarding, I think some time. Am I audible?
Yes, yes, sir.
I think some noise is coming.
Yes, sir. Your voice is breaking.
Yeah, okay. So, in Aparna's leonine facies, hypopigmented macules in the chest and abdomen. Is it really leonine? I do not know. But to me, it doesn't look like a leonine facies. The hypopigmented macules along the facial appearance could suggest Hydson disease. But was the patches anesthetic really? And is there a nerve thickening? That's the point I want to clarify from Aparna. Okay,
Sir,
I will ask. Yeah.
The patches was the patches was not anesthetic. There was no sensory disturbance in the patch, and there was no nerve thickening, sir.
Okay. So that makes a Hansen less likely in this patient. Now coming to the analysis of each of the findings. The high mental functions, patient has got a delayed recall and error in making hands of the clock. Definitely that shows that it's got a defective. Clock drawing is abnormal, suggesting that loss of concept, suggesting an impaired executive function, suggesting a dorsolateral prefrontal lobe dysfunction. Cued recalls also suggest that the patient has got the same frontal lobe involvement and not the temporal lobe involvement, because the retention is normal. Only thing is the recall is affected, again pointing to a dorsolateral prefrontal lobe involvement. So he has got the high mental functions, he has got some dysfunction of the prefrontal lobes. Now coming to the cranial nerves, so all these things are normal. I highlighted the abnormal one, bilateral sensory neural hearing loss, that was confirmed. Then in the cranial nerves, the findings suggest sensory neural deafness. No, the localization for the hoarseness suggests that laryngal nerve rather than the 10th nerve proper, because there is no palatal weakness and in this patient, or pharyngeal weakness in this patient. But as told before, I will also consider partial 10th nerve affection. You may ask why? Because the common sense tells me that a pathology that affects the 8th nerve should have logically affected the 10th nerve also, rather than its branch in the neck. So that if I want to localize this as something in 8th nerve involvement in the meninges or somewhere there, then another lesion in the neck seems odd for me. So I like to think that more likely there's a partial 10th nerve involvement. So if there is evidence of, peripheral nerve involvement after examination, I will definitely consider recurrent nerve as a cause of the hoarseness of voice. But subsequent examination tells it is not like that. Now come to the motor system examination, as opposed to we thought mononeurus multiplex, etc. in the history, but we found pyramidal signs, spasticity, but with relatively normal power. And these are all been highlighted. So in the motor system examination, patients bilateral pyramidal tract affection causing severe spasticity of both lower limbs. And regarding the sensory, it's only confined to the toes. That involvement will not produce any significant ataxia at all. Because if the joint sense is confined only to the toes, without affecting the other area, it will not cause sensory ataxia by itself. This is also shown by the fact that patients, the rhombogism is negative. And regarding the timed vibration, I am not at all a fan of or favoring in this timed vibration, because it's prone to much errors. Because by the time you take the tuning from one area to other, the vibration will go away. So the time vibration is not at all a good method to assess the vibration. It's better to say yes or no. That's it. That's it. Better. That is enough for me. Now, the rest of things you have already said. Now, how do I interpret the sensory findings? Yes, only mild involvement of the posterior column sensation. Impaired, as told before, impaired JP sensation confined to the toes alone will not cause ataxia. I would have given more importance to a positive or absent rhombogism, and this is more objective rather than an impaired sensation compared to the toes alone, as responsible for the ataxia. So here rhombogism is negative. So this sensory involvement is not causing its ataxia at all. And this next part is his fingernail. There is ample evidence of a cerebellar involvement. But I got some clarification regarding this finding which you showed. Look at the finger nose involvement. It's not much of a finger nose ataxia. This is almost normal. Left side is mildly abnormal. It's there. It is there. I do not disagree with that. It is there, of course, but if we look at the lower limb involvement, it is much gross than that of the upper limb. See, that is severe involvement in the lower limb compared to the upper limb. Lower limbs are more affected than the upper limb. That also you take. Okay, this has got an include the importance of localization that will come later on. And he has got a significant or a severe gait ataxia. Tandem walk is grossly defective. So where do you localize a cerebellar lesion? You know, it's not a sensory ataxia, it's a cerebellar ataxia. He had no nystagmus, very minimal upper limb incoordination, and moderate lower limb incoordination, marked gait ataxia. There is no nystagmus, means it is not a pancerebellar involvement. Flocon lobe is not affected. The fact that he had lower limb incoordination with marked gait ataxia, with a very minimal upper limb incoordination, suggests that its antelobe of the cerebellum or the superior vermis is affected. If the hemisphere is the one which is largely affected, upper limb incoordination would have been also gross. In fact, more affected than the lower limb. So ataxia more confined to the lower limb with lower limb incoordination, with less of affection upper limb would make me think more of an antelobe of the cerebellar involvement. So what I observed in the examination was that he has got bilateral sensory hearing loss, mild pyramidal signs, because there is no weakness due to the pyramidal weakness. Finger nose involvement is only very mildly affected. Our shield tension is more affected. Gait ataxia is very dominant. Rhombox is negative, telling you that it's not a sensory ataxia. Site of cerebellar affection more likely in the anterior lobe with affection of bilateral 8th and partial 10th limb involvement. So final discussion, the possibility of PNS affection or multiple root affection, etc. are ruled out. The main site of affection is cerebellum, bilateral sensory 8th and bilateral 10th limb affection. The site affection is very unlikely to be in the brainstem to explain the cerebellar affection or the bilateral 8th and 10th limb involvement, because already told before, a lower brainstem lesion seldom produces bilateral deafness without affecting other structures in the pontomedullary region. So it has to be not inside the brainstem, just outside the brainstem. So most likely cytopathology is in the leptomeninges with or without affection of the pachymeninges. How to explain all these things? Suppose the strong possibility of a superficial siderosis, which can classically produce deafness and cerebellar signs, can also cause spinal cord affection producing pyramidal posterior column by siderosis around the cord. Here posterior column, the mild joint, the apious loss might have been due to posterior column, but that's not severe enough to produce ataxia. And recurrent ART also favors this possibility. The other possibility is a chronic meningitis, which may be lepto and pachymeningitis, which involve the lower cranial nerves as well as cerebellar affection. Maybe something like idiopathic IgG4 disease or other non-infectious inflammatory disease like sarcoidosis. The other rare possibility of is tuberculosis, separative pachymeningitis, less likely with a long duration. So my first possibility would be superficial siderosis. Second would be other causes of non-infective chronic inflammatory pachymeningitis. That is my log, which can explain everything in this patient. That is my, thank you for listening. Shaji? Shaji?
May I ask
You are
one
muted.
question before that?
Yeah, please, sir.
Hello. So, how are you going to take account of HIV positivity in this case? Are we ignoring that, or do you think there is some
No, I did not
that
ignore that.
there could be some differential diagnosis
because
coming up from that also?
Yes, that's why I kept the possibility of an HIV-induced syphilis as well as tuberculosis as the cause of a leptin pachymeningitis. But what I was trying to say is that the site of lesion is not in the parenchyma, but has to be in the multiple nerves as well as in the cerebellum. That is my localization. To explain that pachy or leptin meningitis, I will consider infectious cause like syphilis or tuberculosis is a possibility. But the duration is too long to think of that possibility. That is why I kept it as a third possibility. 2 years duration.
Right. No, it was an excellent discussion, and you have justified the clinical anatomical science in a very eloquent way. So, no doubt,
Thank you,
hats
sir.
off to you, sir, for that. I was wondering for the students, of course, because all the time HIV and the ART was there. So, we might give some account to the infective etiology, little higher up than superficial cirrhosis, or I mean, but you also given enough reasons why you want to put superficial cirrhosis first, and particularly RTA history. So let's see what comes up. Saji, it's your turn now.
Any comments from audience? It's open for discussion regarding the localization, etiology. Any other comments, sir? If there is no other comment, shall we go to the investigation, sir?
Yeah, no, please do. Please
So
do.
there is a question
Yeah.
on how did you confirm SNHL as only ABC positive?
Yeah, because the patient's got absolute bone conduction is decreased and the air condition is better than the bone conduction. That tells you patient's got a bilateral sensory neural deafness.
Thank you, sir.
Yeah.
If there is no other queries, we'll go to the investigation. Dr. Aparna?
Yes, sir. Yes, sir. Investigations.
Yeah.
Investigation showed an eosinophilia. HP was 13, total count was 5,300, and eosinophilia was present. Eosinophilia was about 23% in the DC, and peripheral smear showed eosinophilia with no features of any macrocytes. And the absolute eosinophil count was 1,500 with the IgE more than 2,000. The ESR was normal, X-ray ECG was normal, and renal function test and the electrolytes LFT was all normal, and the vitamin B12 was 293 for this patient. And HTLV and the HPSAG, HCV all were negative, and the CD4 count was 643, and the viral load was non-detectable. This was the NCS showing, NCS of this patient showed a slight right sural snaps are absent, otherwise all are somewhat normal. And the XSCP was also normal. And the BERA showed all waveforms were not formed bilaterally. And the skin smear was also done in view of this suspicion of this leprosy, and it was also normal. Even after that, we took a skin biopsy from that hypopigmented, that white patches, and it was also normal. Then the USG abdomen was done, it was normal, and 70-degree scopy was done as a part of say, Hausner's of voice, and it was also normal. And the pure tone audiometry showed moderate to profound sensory neural hearing loss in the right ear and mild to severe sensory neural hearing loss in the left ear. And this was the imaging of the patient, MRI brain and spinal cord. The MRI show, this is video is playing, and this shows a bilateral extensive low signal region with blooming artifact in GRA, and lining the surface of cerebellum, especially also in the cortical surface. In the cerebellum, folia, vermis, and dentate nucleus more affected, and also brainstem, cranial nerves, and spinal cord. The entire length of the spinal cord is affected. We show that the cauda equina nerve roots are also affected, and there was a SLEC, that is spinal longitudinal epidural collection from C2 to D9 that was causing the cord indentation. There is a SLEC. And the cord showed a T2 cord intramedullary hyperintensity from the C2 to D4. And this show the cauda equina nerve roots are involved, and also the hemosiderin deposits. The extension of the SLEC can be viewed in the MRI. The SLEC is beautifully visualized here. This is the this is the film of the same patient already shown. So the diagnosis was the sensory hearing hair loss with the cerebellar ataxia and bipyramidal signs, superficial fibrosis secondary to chronic intracranial hypotension in an immunocompromised patient. The odd points of this diagnosis was there was no features of any intracranial hypotension, and there was no radiological features of any SIH in the brain MRI. Sir.
Okay. Madhu sir, so any comments why he doesn't have any features of intracranial hypotension, no headache, no other features?
No, in fact, one of the causes of superficial sclerosis is SLEC itself, because what they postulate is that the dural tear that can be when there is a seepage of the fluid outside, the bridging veins get torn and can produce a bleed in the subarachnoid space and can later on produce sclerosis. And in fact, why there is no intracranial hypotension is because that may be there and may not be there. Because here the leakage in the spinal cord only, not in the intracranially. So that need not necessarily reflect in the intracranial cavity. Sometimes it may not be there. That is why called the spinal. In fact, in all cases of in SIH, the main problem is actually the spinal cord, spinal canal, rather than the intracranial compartment, because there is an obscure or overt leak may be there in the dura that is causing his hypotension, hypovolemia, and then this thing. That may not reflect. So, in fact, I presented 2 cases of brachial amyotrophy due to SLEC without any features of intracranial hypotension. They presented with progressive anterior constant loss due to spinal leakage of series of fluid. Somebody asked about the sensory loss here. The sensory loss is due to the cord involvement. We know after examination, history-wise, we thought it could be due to neuropathy and all, but after examination, there is no evidence of any radiculopathy, or evidence of neuropathy. It's most likely due to the posterior column involvement and the spinothalamic tract involvement inside the spinal cord due to the cirrhosis itself. Cirrhosis can strangulate the spinal cord. Not only that, can produce secondary ischemia, also can cause. That may be the reason for the sensory loss. But that is only very mild in this patient after examination.
Whether they try to do the blood pressure, whether it will aggravate this condition, whether he will become symptomatic. So far, he is not symptomatic. Suppose we are planning to get blood pressure. So far, he doesn't have other than such anything that is making us worry to do this.
Sorry, you're not audible, Dr. Shaji.
Hello,
Dr.
sir.
Shaji, kindly repeat. You're not audible.
Shaji, I think I can read your
Can
question.
you hear, sir? Can you hear, sir?
Yeah,
now?
you can. Yeah, you can
So
hear.
this
We can
patient,
hear you.
this patient was relatively stable, except he is having ataxia. We are not done any intervention for this patient like blood patch and all. What we are worrying us, if we do some intervention, whether he will become more symptomatic with regard to headache and all. So we are not done any intervention for this patient. How we will go for with regard to the management of this patient? That is our worries.
Here,
Further
then, in fact, here there are also other reasons to account for the heat siderosis. He has caused multiple RTA. He can have intracranial hemorrhage also. That also can lead to siderosis. Apart from the SLEC. SLEC need not necessarily be the responsible for the heat siderosis in this patient. But I agree with you. Regarding the management, I do not know how to go about in this particular patient. Since he is not progressing, I think we can wait and watch.
But he's worried about the ataxia.
That it's not going to improve anyway. So what literature says that it can gradually progress over a period of time. But that cannot be prevented even with this thing.
Shah sir, what is your comment, sir? Your comment, sir?
Sudhir
Sir, comment.
You're muted, please. You're muted, sir. Unmute.
Sudhir sir, you are muted.
Okay, yeah.
Yeah, sorry. I agree with Professor Madhusudan that it's very difficult to manage. Even CSF, to contemplate a CSF is also a problem in this case. So I don't know for this kind of specifically cirrhosis with more involvement of spinal cord. I mean, it is not easy to do any intervention. So Dr. Shaji at the moment must tell inactivity and just closely watch how is the patient and do symptomatic treatment and physiotherapy. That's it. I was wondering why there was a mention about thickened nerves and leonine phase and all that. Was it relevant anyway or just?
No, there was no thickened
That's
nerves. No, there was no thickened nerves. She said no thickened nerves.
All right. If anybody from the house wants to comment or share
Yes.
the experience of treatment of superficial siderosis, particularly in spinal cord area.
Sir, can I just show some slides on the Slack?
Yeah, please.
So, spinal longitudinal epidural collection or SLEC. This suggestive of a spinal CSF leak, which usually result in the intracranial hypotension. And this chronic SIH can present as superficial cirrhosis without headache. This is an article showing the SIH, and they show the rare presentations as superficial sidrosis, then abducent nerve palsy, then hemifacial spasm, syringomyelia, and also behavioral variant FTD and bibrachial amyotrophy. And this SIH presenting as superficial sidrosis occurs only after a long duration. And they says that the features of SIH in MRI brain may be absent in this patient. And this is an article from Neurology Journal. This shows, this says that the superficial cirrhosis and the ventral spinal CSF leak have no history of SIH related symptom if it is of a long duration. And this may be due to the recurrent intraspinal hemorrhage from the friable vessels, or the recurrent bleeding from the superior cerebellar bridging veins that are stretched during the brain sagging. Thank you.
And have you reviewed the literature of management of SIH of such situation?
Yes, sir. The literature say that initially non-targeted epidural patches, and later, if it is not improving, targeted epidural patches. But the more literatures are more supporting those patients with a headache and all, not chronic SIH.
Yeah, that is well known, but for such symptomatology, such presentation, are there any matching experience from any other center, or even case series, or even individual cases if there are? Otherwise, epidural patches would be a standard answer for some things. I agree.
There was not much literature on those patients with the superficial cirrhosis which are treated by the epidural patching. So we are in a dilemma of treating this patient, whether to intervene or not.
The problem is that this cirrhosis occurs years after the leak. Okay, and this, in fact, the cirrhosis secondary to the changes in the glia is converting the heme into the hemosiderin pigment, and that will not revert back even if you correct the leak. That process will go on because the glia will enter this this thing will convert into hemosiderin. Only further, if it is further progression, also only can be prevented.
Okay, Dr. Shaji, do you have to share any comments, or you want to put some closing lines from your side?
Shaji?
Hello, can you hear me?
Yeah.
Hello? So what I want to tell is that actually this patient is relatively stable now. The sir is discussed very nicely. The message is that whenever somebody is present with past history of any recurrent trauma, subsequently having dominantly ataxia symptom, especially cerebral ataxia and lower cranial nerve palsy, one of the commonest differential diagnosis should consider is superficial cirrhosis. Trauma, past history trauma, ataxia with lower cranial nerve palsy. That is the message from this case. And Madhusar is discussed the history very nicely, and investigation very excellent discussion. We learned a lot of things from sir. Anything, sir? Sudhir sir? Anything? Any comment?
No, I think many times we as neurologists are able to give the perfect localization diagnosis as sir did in this case, but sometimes we are not able to give any management answer. This is one situation where we would like to explore. Even somebody gets a proper answer, do let us know. We would be happy to know that. If somebody has come across such situation, it would be nice to know his or her feedback. But thank you very much for wonderful case, Dr. Aparna. Your presentation was quite optimum, very good. Dr. Shaji, thank you for your comments, and heads off to Sir, Dr. Madhusudan sir, for giving a nice exploration of the symptomatology and localization with a beautiful pause in between your discussion. Thank you very much, sir. So nice.
Thank you, sir. Thank you.
Sir, I missed. Sir, I missed the. I joined the last part of the discussion.
Welcome, welcome.
Lakshmi sir.
Sir, my Air India flight, the
welcome,
AOAC,
doctor.
FLSC conference, the flight late ho gaya, so just now joined. Sir, my hearty thanks to both Shaji and Madhu sir for giving this. I saw the case. I knew the case because I attended the CAN meeting. It was one of the wonderful cases. That's why I thought the entire country should benefit by this discussion, sir. These two cases we chose because they were outstanding cases. That's why I thought we should share it in our platform, sir. Thank you so much, sir. Thank you so much. Thank you.
Thanks, sir. Thank you, Lakshmi sir. Thank you, Madhu sir. Sudhir sir.
Thank you.
Over to Chaddaji for
Thank you
thanks
very
giving.
much, sir. So, thanks to all of you. Today we are incredible grateful to all of you for joining us in the Secret of Neurology, and we are successfully completing the 55th session of the insightful web series. On behalf of the Intas Pharmaceutical, I, Arun Chadha, Vice President of Intas Pharmaceutical, extend heartfelt gratitude to all our esteemed delegates for joining us on this momentous journey over the past 55 months. And a special thanks to our esteemed course director, Dr. Sudhir Shah sir, and Dr. Lakshmi Narasimhan sir for designing such a fantastic web series on neurology, which gives a valuable resource to all the DM and DNB students. And we are incredibly grateful to the young neurologist, Dr. Aparna Amanna, for sharing their insightful case presentation. And we are thankful to Shaji sir for localization in this case, and we are thankful to Dr. M. Madhusudan sir for giving insight of this case and providing the crucial learning points and proceeding of the unique presentations. Once again, a heartfelt thankful to all of you for gracious presence. It's being a true pleasure being with all of you and in this 55th session of Secret of Neurology. And once again, we are eagerly waiting for your return for the next highly appreciated session of the Secret of Neurology on March 29th. Until then, stay safe and take care. Thank you. Thank you to all of you. Thank you, sir.
Thank you.
Thank you
very
so much, sir.
Thank you very much.
Thank you, sir. Thank you. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you.
Good night.
Thank you, sir.
Thank you.
Thank you.
Thank you, sir.
Thank you, Lakshmi.
Thank you, sir.
Lakshmi sir.
Thank you so much, sir.
Thank you, Lakshmi.
Thank you.
Thank you. Thank you. Thank you.